Welcome and thank you so much for being interested in my work. The topic is priorities in orthodontics. So this is the outline. I will talk about knowledge, I will talk about goals, how to define and achieve in a predictable way the goals. I will talk about simple, what is simple. I'm interested in whatever is simple. And I will talk about minimal invasivity. Of course, at the end, I will draw some conclusions, but let me start with a short introduction. The Dunning-Kruger effect is a cognitive bias in which beginners usually mistakenly assess their cognitive ability as greater than it is. This happens usually when we start a new career. This happened to me in 1985. I was a young orthodontist, unskilled and very unaware of it. Then, during these last decades, during this last year, my experience increased, and with the experience, my knowledge in the orthodontic field increased. So now I think I'm around here, and this is a good time to share with you what I learned, what I'm doing now, looking at the future. What I learned in these 30 years, a lot of things. I learned that it is possible and beautiful to fix the malocclusion and achieve a good dental result, a good occlusion, a stable occlusion, good function. I also learned that we can change the profile, the face of the patients, not only by surgery, but also by working properly during growth. But what was amazing to me was to realize that orthodontics is the best way to change the quality of life of our patients. And this is something which really is exciting. Of course, we have to pay some cost. Costs are not only financial, costs are also biological. When I say biological cost, I mean overtreatment, I mean side effects, I mean complications. And complications greatly influenced my priorities. When I say complications, what do I mean? This is a young girl, 9 years of age, in the last stages of the mixed dentition, with an impacted canine, the upper left canine, transposed impacted canine, and this impacted canine resorbed in a very severe way the root of the upper left lateral incisor. So I decided to extract the lateral incisor and to move the canine in the place of the lateral incisor. Not so easy, but not so difficult. I had a lot of space. So I asked the surgeon to do a flap in order to place a bracket, and this is June when I started pulling the canine. This is October, after 4 months, the canine still where it was at the beginning, no movement at all. So I asked the surgeon to do a second surgery. Then we placed also skeletal anchorages in order to keep the molars. I was using only the molars at this step to move the canine down, to keep the molars where they are. So an absolute anchorage, but once again, after 2 months, no movement at all. In 2010, I had a Combeam CT machine in my office, a great investment. I learned a lot of things, so I had the possibility to diagnose what was going on. And I noticed an external root resorption at the cement enamel junction level. This is an invasive cervical root resorption. In 2010, I didn't know what is the name of this illness. In 2013, Adrian Becker published this beautiful article about invasive cervical root resorption, 15 canines, all extracted. Of course, I couldn't think that I must extract this canine. I already extracted the lateral incisor. So I asked the surgeon to do another surgical approach, surgery number 3. And I was behind the surgeon when he was saying to me, I don't find the hole. And I said to him, you have to look for it, because for sure there is a hole a little bit more distal. And she went on removing alveolar bone. At the end, he found the resorbed area. Then he removed the bone around the resorbed area 4 millimeters apically in order to allow the flap to heal and leave a good area for the epithelial attachment. And he removed the bone. Then he did a pulpectomy, and at the end of the surgical approach, this is the situation with the sutures. But the damage was done. The damage was done not on the canine. The canine, we managed the canine at the best. The damage was done on the adjacent teeth. On the distal surface of the central incisor, on the mesial surface of the premolar. The surgeon removed the periodontal support, and now is a big problem. So this is the provisional filling of the resorbed area. These are the sutures. This is the coagulus on the premolar. And now it's time to restart the orthodontic treatment again. This is the sectional wire during the extrusion. During the extrusion, it is very important, very crucial to use a proper bracket to bend the wire in order to create a root palatal torque, keep the root of the canine inside the alveolar bone, but in 3 months with this not difficult, but precise biomechanics, the canine was coming down very fast. This is after 5 months. This is after 6 months. The gingival margins are almost at the right level. This is 7 years post-op, again, 7 years after the orthodontic treatment, with a composite restoration made by Dr. Patrizia Lucchi, and with the final result, which is achievable and also stable, 6 years post-op. What I learned by this treatment is that complication really can be very, very important in our work. I learned that the canine, now the lateral incisor, went well, but I also learned that we can do mistakes, we can do damage, we can create, in this case, damages on adjacent teeth. And this patient lost periodontal support on the central incisor and mesially on the premolar. But I also learned a very important thing, that orthodontics is the unique and the best and the only way in dentistry to regenerate soft tissue. Only by being of the orthodontic treatment, we can regenerate from zero to a lot of it meat, a lot of soft tissue. But we are not periodontists. We are not interested in only in the periodontal aspect. We are interested in occlusion and in the profile of the patient. This is the patient at the beginning of treatment. This is the patient at the end of growth. So what I really learned by this patient, who showed this very unpredictable way of growing, is that after 25 years of working, my problem is that I was not able to do the most important thing, a diagnosis and a growth prediction. So the problem is that even now that I'm more than 60, I know that I don't know when I think about the most important thing in orthodontics, which is growth prediction of our young patient. This is more or less 70% of our daily work, growth prediction. So knowledge is the most important thing, and I think knowledge is something we must achieve at the best in order to go to work without any problems every day. How can we how can we build up our knowledge? First of all, I think we need mentors. In my case, one mentor was Dr. Giuseppe Cozzani. Here is Giuseppe together with Bjorn Zachrisson, a close friend and mentor. Of course, Dr. Vince Kokic, a mentor and a professor and a teacher and a friend to me. This is Dr. Massimo Ronchini, one of the most elegant orthodontists and skilled orthodontists in the world. Dr. Renato Cocconi, Dr. Lorenz Moser, Ute Schneider, Bjorn Ludwig, all these men were very close and are very close to me and were precious mentors. Then there is another way to achieve knowledge, professional contest, doing orthodontic competitions. It means present cases. The Italian Academy of Operative Dentistry, the Italian Board of Orthodontics, the European Board of Orthodontists, the Anglo Society of Europe. Whenever I was presenting cases to be judged by skilled professionals, I learned a lot. Then publish something when we have something to say. When you have something to say, you must publish in a good way and maybe achieve some awards sometimes. This is a nice way to understand that you did something good. And this allows you to work even more and to learn even more. Professional contest. Whenever I go and present something in front of colleagues, I feel I must be sure on what I'm saying and I must study and increase my knowledge more and more. And at the end, of course, scientific evidence. In 2021, we must provide treatments which must be also evidence-based. What did I learn by the scientific evidence? I want to be very sharp with you. I learned that PRCT, prospective randomized clinical trial, didn't provide so much more knowledge than was previously available from retrospective studies. I learned that long-term stability, if you are thinking about the lower incisor, is a dream. We need lifelong retention if you really want to prevent aging of the teeth. And aging means movement. Lower incisors, more or less, always move. Also in the extraction cases, 1-2 millimeter. I learned that malocclusion is not a disease. And I learned that if the goal is long-term periodontal health, space closure is much better than implant substitution. But even more, what I learned is that if we limit the discussion to orthopedic treatment of growing patients, which is the vast majority of our daily work, nowadays we still do not know what to do or even how to research the problems. And this is a big problem. In 50 years, we didn't do any step forward. Look at these two class 3 patients. On the left, a severe class 3, look at the decidus canine, no mandibular shift. If you look at the age, one is 9 years of age, the second is 6.5 years of age. On the left, you have a very severe class 3, on the right also. If you look at the numbers, the cephalometric assessment, and also if you do a more sophisticated analysis, you will not be able to find major differences. They more or less show the same numbers. Well, this patient, the more severe, I started treatment 10 years of age. When he is 21, shows this occlusion, a class 1 occlusion, this profile, and of course, it doesn't need any second phase of treatment. The second patient is this. When he is 16, He already showed a severe class 3, an open bite severe class 3, and of course, if you want to fix the malocclusion, the problem, it needs a surgical approach. It would have been impossible to predict this huge difference among these two patients. So nowadays, more or less, we do the same, we achieve the same results we were achieving 40 years ago, but we achieve the same result in an easier way. Everything is a little bit more easy because of the technological advancements. Straight wire, night tie, skeletal anchorage, 3D, clear aligners, a lot of advantages which allows the orthodontist to achieve good result in a much easier way. In 1988, I was young, unskilled, unaware of it, but with a lot of courage. I started this treatment, a 6-unit bridge on this class 2 patient. I removed the crown of the upper central and lateral left incisors, lost because of a traumatic injury, and I closed the spaces. Space closure means canines in the place of the lateral incisor, premolars in the place of the canines, the upper right lateral incisor in the place of the central incisor, the upper right central incisor in the place of the upper left central incisor, through the midline. Also the root through the midline, only by orthodontics. And I learned that not only it is possible to transform, to change a wide edentulous cella in a papilla, I learned that only by orthodontics, by intrusion, by extrusion, we can change the periodontal profile, change the anatomy of the soft tissue, create attached gingiva sometimes, only by means of orthodontics. So move the gingival margins and change the aspect of the soft tissue and, of course, of the alveolar bone only by orthodontics. This was amazing, but treatment time was long. Nowadays, we can do difficult treatments. In this 13-year-old patient in 2014, I decided to close the space in the upper right hemi-arch, which means I don't want to move the upper left hemi-arch, I just want to move forward all the teeth of the upper right arch. And I can do it nowadays in a much easier way with the 2 mini screw in the palate. I learned this procedure by the Germans, Dr. Ludwig, Dr. Benedict, and their co-workers. And this is the beautiful appliance made by OrthoCheck here in Italy in order to let me move forward everything, molars, premolars, canine, and lateral incisor in the place of the central incisor, without using the lower jaw. No braces in the lower jaw, nothing in the lower jaw. The anchorage was only in the palate, on the TADS, on the upper left hemi-arch. 10 months of treatment to close the space unilaterally. This would have been impossible, of course, 30 years ago. This would have been impossible 15, 20 years ago. Now is absolutely my daily work. 10 months. But even now, even with the technological advancement, if space closure takes 10 months, orthodontic finishing takes 8 more months, because finishing is always a matter of orthodontic art. We have to be very focused on details in order to finish at the best these treatments, and takes time. In this case, 8 more months. Of course, with braces upper and in the lower jaw. At the end of treatment, the central incisor on the left is the natural central, on the right is the lateral incisor. Intruded, you see the canine, the extruded canine in the place of the lateral incisor and the premolar, the intruded premolar, in the place of the canine. So intrusion and extrusion to achieve a natural-looking gingival margin, level of the gingival margins. But the most important thing is that treatment was completed before adolescence. If we plan a prosthetic replacement, usually treatment can be finished only at the end of growth, and you never can plan how many extraordinary maintenance will be necessary during life. But apart the aesthetics of the smile with the lateral incisor in the place of the central, what is important is health. And how can we measure health? This is the only way to measure the periodontal health. A probing around this intruded tooth, no bleeding, no pathologic probing, same of the other side, it means health. 3 years after treatment, once again, health. Health of the transition area, health in the most difficult area to manage in dentistry, which is the transition area where there is a very thin epithelial attachment which has to face a lot of injuries. Brushing, bacteria, and also the orthodontic treatment. How to achieve and how to define the goals. First, we have to define the goal, and then we have to achieve them for sure. This is a 20 years old young woman, class 2 subdivision, another time missing the upper left canine, which is once again impacted, transposed above the lateral incisor. The lateral incisor is not resorbed in the root. Very bad-looking first molars. This is a molar incisor hypomineralization effect. And of course, a class 2 subdivision 2. It means the upper right hemiarch is forward. Not only the midline is deviated to the left, but also the upper right canines, premolars, and molars are more forward when compared to the left side. How can I define, how can I be sure that I will be able to achieve my goals? And what are my goals? The goals in this fragile patient is do a treatment which must be the shortest I can. So I decided to start a treatment which can be done with a lower amount of cooperation. So I decided to take a little bit of courage out of my pocket, and I extracted not only the impacted canine, but also the first molars, all the first molar, all 4 first molar. And then I also decided to extract the upper right premolar in order to be very fast in fixing the upper midline. With the extraction of the upper right premolar, I can fix the midline in a few months, and then by means of the tats in the palate, I can move forward all the posterior teeth in a short time, in a reasonable time. Don't forget the patient was very fragile. And this is after 20 months, more or less, I am at the end of the space closure and at the end of the orthodontic treatment, but unfortunately, the lower third molar didn't erupt properly, so it took 5-6 more months in order to bring the third molar, the lower third molars in a good occlusion, and at the end, treatment time was a little bit more than 2 years. But the final result is good. I was able to finish treatment just before the enamel of this tooth started again showing problems, and this is how I was able not to flatten the profile and to keep a good interincisal angle. This is not an easy treatment, but the procedure, the orthodontic procedure, was the simpler I could find. But even more, it was the faster way to achieve a good result. A lot of extraction maybe, but we can use the third molar as normal teeth, of course. This is the end 3 years post-op, and the upper left first premolar is in the place of the upper left canine. The premolar was built up with composite by Professor Patrizia Lucchi. And this is probably not a simple treatment, but is the right treatment for this patient. Of course, if I can, I'm very much and much more interested in what is even more simple. And even more, I'm interested in whatever is minimally invasive. A short orthodontic treatment is, of course, very welcome, but sometimes we can treat patients also with a major degree of minimal invasivity. And this is the case of the patient in mixed dentition. When we are able to assign a good diagnosis, when we are able to treat the major part of the malocclusion in the mixed dentition, doing a proper patient selection, this is the best way to achieve a good result in a least invasive way with simple procedures. This is a hyperdivergent class 3 in a young patient, 7 years and a half. And when you are in front of a real class 3, look at the decidus-canine relation with no mandibular shift in a hyperdivergent patient. You, like me, are a little bit scared because this is one of the most difficult malocclusion to be treated. Also because we know that growth could be very negative. Well, I tried to assign a precise diagnosis in this case, and so I found out that this was not only a class 3 hyperdivergent patient. He had a narrow palate. In front of a narrow palate, I always want to create space for the lateral incisor by expanding the palate. So even if the absence of posterior crossbite, I apply a rapid palatal expansion procedure, absolutely banded and bonded on the decidus teeth, 2 bands on second decidus molar, and bonded, the anterior arms are bonded on the palatal surface of the decidus canine. This will not only expand the palate, but also provide space for the lateral incisors, which will erupt spontaneously without any need of other appliances. After 4 years from the first observation, you see the upper arch with good alignment of the anterior teeth. He is now approaching the second phase of the transition, so it's time to take another records. This is the panoramic. You see the crowding in the upper jaw, in the upper arch. You see the head-to-head incisor relation. And since you have class 3 malocclusion, probably many of you are thinking that we should expand the maxilla in order to fix the overjet. What I did was something different. I did another head plate in order to understand how this patient would have growth in the future. And I found out that he was growing in a counterclockwise direction. This is quite good in my opinion. So I worked very much on the lips in order to keep the lower lip against the upper incisor, and instead of expanding the upper crowded arch, I did serial extraction. And after the serial extraction, it was amazing to see in the ears how the teeth erupted spontaneously with no braces, no appliances, nothing inside the alveolar bone, inside the periodontal envelope, in a very precise way, with a good occlusion, a good stability of the joints, and promoting even more better improvement of the profile. This is the patient when he was 25 years old. Now he's a professional, an engineer. And if you look at the interincisal angle on the profile, on the X-rays, you will notice that we are inside the limits of the normality. This is 12 years after treatment, after the active treatment.